Today, we are diving into a really important publication from the Lancet Psychiatry. It's called the Integrate Guidelines, and this is a major global effort to create a single, clear, algorithmic approach for the pharmacological treatment of schizophrenia. The goal here is to standardize and ultimately improve care for patients everywhere.
So for years, clinicians like you have had to deal with all these different guidelines. They're fragmented, they change from country to country, and frankly, they can be super complex and hard to actually use when you're with a patient. Well, Integrate was designed to fix that exact problem. It pulls together a global review of the evidence, a consensus for experts in 30 different countries, and, crucially, input from people with lived experience, all into one unified, practical algorithm. All right, first things first. Before we get into the algorithm itself, let's talk about the core principles. Think of these as the 4 pillars that support every single clinical decision in this new framework.
These principles really set the tone, and it's a proactive and collaborative one. First up, shared decision-making. This is non-negotiable. Next, individualized dosing, which means looking beyond just the standard protocol and considering things like age and pharmacokinetics. Third, and this is a huge shift, is the act early principle. This demands that we proactively assess how a treatment is working and manage non-response quickly. And finally, physical health is a top priority right from day one. You start metabolic management at initiation. The core idea is simple but powerful. You have to treat the body to protect the mind.
Okay, so with those principles as our foundation, let's walk through the treatment algorithm itself. We're going to start right at the beginning with a first episode of psychosis. Phase 1 gives us some much-needed clarity on when and how to start treatment. It should be offered when psychotic symptoms have been present for more than a week and are causing distress. The top recommendation? A D2 partial agonist, like aripiprazole, an agent that helps modulate dopamine activity. And you're going to start at a low dose. Now, this next part is critical. The guidelines also stress something called metabolic prophylaxis. What this means is, if you have to use a higher-risk agent like olanzapine, you should offer metformin right away at the same time.
And here is where that act early principle really comes to life. This timeline is tight and decisive. You assess at week 1, you titrate the dose by week 2, and by week 4, you're at a decision point. If positive symptoms are still there, it's time to think about a switch. But, and this is a big but, you only do that after you've confirmed adherence, and ideally, you're checking plasma levels to be sure.
So let's say that 4-week trial doesn't show enough efficacy. The guideline is clear, it's time to switch. The key here isn't just to switch to anything, it's about being precise. The switch should be to a compound with a different receptor profile. This maximizes your chances of getting a response. Top options include amisulpride, risperidone, or olanzapine. And all through this phase, you should be talking about long-acting injectables to help reduce that risk of relapse.
This brings us to a really critical step, treatment resistance. The definition is now standardized. It's the failure of at least 2 different antipsychotics, where each one was trialed for at least 4 weeks at a proper therapeutic dose. Once you've established this, the next move is a trial of clozapine, and the guideline says to do it without delay. It also really stresses the importance of therapeutic drug monitoring, aiming for a target plasma concentration of 350 to 500 nanograms per milliliter. This is how you make sure it's an adequate trial. But what if you've done an adequate trial of clozapine and you're still not getting the response you need? Well, the algorithm gives us clear pathways for that too. For positive symptoms that just won't go away, you should consider augmenting with amisulpride, aripiprazole, or even ECT. For persistent negative symptoms, the recommendation is to augment with an antidepressant. And notice that no matter which path you take, metabolic management is always a priority.
This focus on holistic care is the perfect transition to our next section, side effect management. The guidelines spend a lot of time on proactively managing physical health because they recognize it's just as important as efficacy for good long-term outcomes.
The cardiometabolic protocol is so practical. Monitoring is systematic. You start with a baseline, check weekly for 6 weeks, and then you move to quarterly. The triggers for when to intervene are also very specific, a weight gain of 5% in 3 months or hitting certain BMI thresholds, and the pharmacological interventions are clear too. First line is metformin, and they also propose GLP-1 receptor agonists for obesity.
You see that same clear algorithmic thinking when it comes to neurological side effects. For tardive dyskinesia, the guidance is to switch to agents like clozapine or add a VMAT2 inhibitor. For akathisia, your options include reducing the dose, switching, or adding agents like propranolol.
And for hyperprolactinemia, the strategy is to switch to a D2 partial agonist or augment with a low dose of aripiprazole. See? Every problem has a structured set of solutions.
So finally, what about the long term? Discontinuation is a massive clinical question. The guidance here is extremely cautious, and for good reason. You should only even consider it after at least 2 years of being symptom-free, and that's in a first episode context. And if that decision is made, it has to be done with a very gradual taper over a minimum of 6 months, with really robust monitoring, because the risk of relapse is just so high.
Phew, we have covered a ton of ground, from the very first step all the way to long-term maintenance. So now, let's distill all of this down to the 4 essential, practice-changing messages you need to take away from this.
All right, here are the 4 key takeaways. 1. Be systematic and act early. You need to assess response within 2 to 4 weeks and switch if it's not working. 2. Treat the body. Proactive metabolic management isn't an afterthought. It starts at initiation. 3. Clozapine urgency. After 2 treatment failures, do not delay starting clozapine and make sure you monitor plasma levels for an adequate trial. And 4. Precision switching. When you do switch, make sure you choose a drug with a different receptor profile. Everything we've covered today is grounded in the evidence and consensus that's detailed in this landmark paper. Now, just remember, this explainer is for educational purposes for healthcare professionals. For any clinical decision-making, please, you have to refer to the full guideline and your local prescribing information.